Thank you everyone for coming tonight. We're all in the correct place, yes, for the low back pain workshop. So welcome everyone tonight to the back pain workshop. We're going to start off with a little brief introduction of us as a clinic and as a company. The name of our company is Physical Therapy Institute, as you may have found out already. A couple things that I want to mention with that is we're a private practice, physical therapy owned, which means the point that I want to get across is that it enables us to do some of these talks out in the community. We're not necessarily linked up with any one insurance group or physician group or anything like that. It gives us a lot of freedom to, most importantly, treat patients the way that we feel that they need best treatment without any powers above telling us how to do things. So it's physical therapy run, physical therapy owned type operations that we do. Specific to the Moon Clinic here, everyone met myself tonight. I'm Jeff, I'm the physical therapist here and the center manager. And then you met Stephanie as well. She's physical therapy assistant. So her and I are the clinicians here. We both work with the patients. And then the other thing that I have mentioned on there that we'll reiterate a little bit more, but a point that I want to drive home about us, we're hands-on specialists, or what we refer to as manual therapy, hands-on approach. Like I said, we'll talk a little bit later about the importance of that and the effectiveness in our treatments, part of the treatments that we offer. And as you may have been able to tell already, we like to have a nice environment here, a family type environment when you come in. So to kind of outline our folks.
Excuse me.
Yes.
I have a question.
Sorry.
What do all the initials behind your name mean?
Oh, thank you. PT and DPT, that means I got my doctorate in physical therapy.
Well, officially we call you Dr. Jeff.
If you want to. I don't require it unless I don't like you, which I don't ever require. But and then OCS means I got my an extra certification of board certified specialist in orthopedic physical therapy, which is muscles, bone, joint kind of therapy. And then similarly, the last two at the end, other kinds of certifications along those lines, and orthopedic manual therapy, those hands-on approaches we were talking about. So, thank you.
What about you, Stephanie?
Yeah.
Mine is that I'm a licensed physical therapist assistant. I'm also a certified athletic trainer and a licensed massage therapist.
Okay. Thank you.
Thank you.
To sum it up, we both went to school and extra for a lot of things, just to help you all better.
And you know, kinesy therapy.
That's right. It's a part of it. So the focus of our workshop tonight, we're going to cover some of the common causes of low back pain, probably the ones that, some things that you've all heard, either you may have been told that you have or you've heard of. We're going to reveal the #1 mistake that people make with low back pain. We'll talk a little bit about physical therapy, a little bit more in depth than what I kind of said already, and more specifically about physical therapy here and what we offer. And we're going to combine all those topics together, okay? We're going to take those common causes of back pain that we will talk about, what we do in physical therapy, and kind of mesh those together at the end, tie it all together, and help you forward the next steps to take in helping your pain. Just a brief survey of the crowd tonight. Who here currently has back pain or sciatica? Okay, who's here maybe just for like some information for the future? Maybe you know someone with back pain. Okay. How about physical therapy? Who here has tried physical therapy before? Whether it's for this problem or for something else, so you have a little familiarity. Okay. And I want you to think to yourself at this point for a moment. We don't have to show of hands of this, but I want you to think about your back pain that you're here for tonight. I want you to think of how long it's been going on, how long it's been bothering you. Okay, those of you who maybe it's a newer injury, less than 3 months, or maybe once it's been longer than 3 months, and I want you to start thinking to yourself kind of what side of that you fall into. Then I want to direct your attention to the little diagram on the right. I want you to think about how many of those squares are starting to or have become affected. You can just kind of think to yourself for a moment, and I want you to keep that in mind as I talk through some of these back pains that we're going to get into next, okay? And then we'll try to, hopefully if you keep that in mind, we'll tie it all together by the end of this, okay? Okay, so before we get into some of those really common causes of back pain that I know you all have heard about, I want to bring this idea up of what we call mechanical lower back pain, okay? I just want to plant this bug in the back of your mind right now. I will bring this slide back towards the end. But I want to show it right now. Hopefully when I bring it back up at the end, it starts to make a little bit more sense to you, okay? The mechanical lower back pain, again, like it says up there, I want you to think of like a car. I think of us physical therapists as like the auto mechanics of the human body. So something's going wrong with your car, it's making a funny noise, or it feels like something when I do something. How about same thing in the body? It hurts here when I do this or that. You take it to the auto mechanic, you take your body to the physical therapist. Okay, I want you to at least think of that concept right now, and we'll discuss a little bit more. 90% or more of patients we're finding have some form of mechanical back pain. A lot of different kinds of mechanical back pain that we will talk about. But I want to bring this topic up now. Like I said, that 90% of us walking around with back pain, it tends to follow some kind of mechanical pattern, movement-based pattern. We'll talk a little bit about imaging later, but with mechanical back pain, we're finding that there's no need necessarily for imaging other than just creating some unnecessary anxiety and things like that, okay? I'm going to bring that back in a little bit, but like I said, I just want to plant that bug right now because that's kind of a big topic, an overarching topic that I want to drive home tonight. Another thing that you can think of when it comes to mechanical back pain, I want you to think of this phrase right here. So if it's reproducible, then it is reducible. Meaning if you can, or if we can in a physical examination, if we can reproduce your symptoms with a certain movement position, then chances are that with conservative therapy treatment, we can then reduce it, meaning it's movement related, therefore it's mechanic related, okay? You can try it if you like. But so we're going to get into some common causes next that I know you've probably heard of, okay? How about the herniated disc? Who here has heard of herniated disc? Maybe been told that we have, or along those lines. So, a little bit of a description of a true herniated disc, or true, when back pain truly can come from a herniated disc. A couple of descriptors, key descriptors, they tend to actually be younger. Less than 35 years of age on average, okay? It's a little bit younger. It's usually the result of some type of an incident or an injury activity. A lot of weightlifters, things like that. Lifting a heavy box, kind of like it says there. The increased pain when you're doing some form of forward flexion movement that we call it, aka a bending or a lifting, something when you're bringing your body forwards. Put a lot of pressure on the back of the spine, a lot of pressure on the disc, okay? Likewise, it decreases pain when you get out of that position or you stand nice and tall, or you kind of get in a position like the fetal position, or even walking, that kind of takes pressure off of the back like that, okay? Those are the descriptors that we want to think about when we're thinking about true pain from a herniated disc, okay? So to illustrate that a little bit, as a diagram there, my analogy that I like to use for the herniated disc is the jelly donuts, okay? So our disc is made of a couple of different kinds of tissue. That outer surface, and I'll illustrate on the healthy disc, that outer surface is a little bit of a thicker, more of a firm type of a tissue, similar to the dough of the jelly donut. On the inside of the disc, we have more of a jelly, mostly water-like kind of a tissue, similar to the jelly inside the donut. Okay, in a healthy donut or in a healthy disc, it's all enclosed or encapsulated and it stays nice and contained. It allows us for shock absorption in space of the spine. What happens in a herniated disc, or when a disc starts to become herniated, that outer layer starts to rip. Once that starts to rip, that fluid-like material starts to leak out, as illustrated on the next picture over. Similar to that jelly donut, what happens when you take a bite out of it, or maybe you squish it, that jelly starts to come out. The issue with that is once that jelly, or once that fluid starts to leak out, it starts to put pressure on the structures outside of it, which are our nerves. We have nerves that run at each level of the spine along with the disc. So when the fluid starts to leak out into the nerve, that's when we start to get the pain, okay? In a nutshell, that's kind of the story of a herniated disc, or sometimes referred to as a bulging disc, okay? Our next topic is either degenerative disc disease, arthritis, stenosis. We can kind of sometimes use those terms synonymously in terms of, at least in terms of their presentation, okay? You could think of it almost as the opposite of the descriptors that we just spoke about with the herniated disc. They tend to be a little bit older. So usually 50 years or older, and we have back pain, they tend to be a little bit more of this group. It increases now when we're standing and walking and we're upright. Okay, when you're upright and you're weight bearing, that compression, that's when you get more of your symptoms and more of your pain. Likewise, when you sit or you bend forward, you kind of give yourself a little bit of a reprieve. That's when the symptoms tend to subside in this situation. A more functional analogy is if you're out shopping, you're standing and walking for a long period of time at the store, you get that cart and you feel like you have to lean forward on that cart, and that helps relieve. A lot of times those are like some real life descriptors. You might be dealing with more of a degenerative disc, arthritis, stenosis, kind of an issue. Now, a better illustration of that is this diagram here. So these first top layers are relatively healthy, disc and spine and vertebrae. You can see how we have bones, our vertebrae, and then in between that you can see our discs. Now direct your attention to these lower segments. Can you see how we start to get some narrowing? That's what happens in a stenosis, or again a degenerative type of situation. Likewise over here, a typical healthy lower back, we have a nice space in the bone and the vertebrae for the nerves and all the tissue to run through. What happens in a stenosis, again, that starts to narrow. Stenosis means narrowing, okay? You can have it in other types of body parts as well. Narrowing, meaning you can see all this start to form. That hole is smaller, therefore the space for the nerves and all that other tissue to run through is smaller. And so it's more likely that when you get in certain positions, you really kind of cut off that supply, or you pinch that supply, get those symptoms. A couple analogies that I like to mention with the stenosis type of situation. One I like to describe is kind of like that slinky. We've all played with slinkies before. You kind of give it a little bit of space in between the rings. That's like a healthy back, healthy spine, healthy disc. When you start to compress it, that's when, again, you compress or you kind of cut off a lot of that supply. The other analogy that I like to use is the analogy of the garden hose. Springtime's coming, we're going to maybe be getting out the yard a little bit more, so maybe you're thinking of that. You're out in the yard, you have the hose running, water, someone comes behind you, either steps on it or you cinch it. What happens to the flow on the end? It stops, right? Or it lessens. That's again what happens in a stenosis or an arthritic kind of condition in the spine. You usually typically have a nice space for everything to flow through. Once it starts to narrow, once it starts to degenerate in certain positions, we start to cut that supply off. In the body, we feel that as pain when we get that pinching or that cut off of supply, okay? Good. This next one we're going to talk about is SI joint or sacroiliac joint. Anyone ever heard of that before? Sometimes this is something like when people have maybe been to a chiropractor or some other type of doctor, when they say like your hips are off or something's out of line, something like that. Sometimes it's used in layman's terms like that. Now what I want to emphasize with the sacroiliac joint, this has a much broader range of likely suspects. As you see there, like 15 to 96, but essentially it's meaning that it can kind of encompass anyone that is equally had a chance to get back pain from a sacroiliac joint issue. More so a pain with changes of position or changes of movement. So it's not like herniated disc where it's specifically that forward position that bothers you, the other one takes it away, and vice versa with the stenosis. This is one where being in one position isn't necessarily the common cause of pain, but it's when you change. So I'm sitting, I'm okay, but as soon as I get up, I kind of have that little bit of a hitch, and then I get going and I'm okay. Something like that. Okay? As you start to move, it starts to get better again. The trick with this is that it does not show up on x-rays or MRIs. And to better illustrate the meaning behind that, like we said, those hips are off. So this isn't necessarily something that's structural. This isn't something that we can find on a picture image, like a disc or a nerve being pinched that we spoke about earlier. This is something that usually because of either some type of muscle imbalance or some type of uneven force that was jolted to your body. Has anyone ever stepped off of the last step or stepped off of a curb and you weren't ready for it, and you kind of have that? Or how about this last couple of weeks with the ice? Anyone slip and fall on their buttocks? Maybe not now, but you know what it could be like. Something like that, some type of a jolt, unexpected force. That's what kind of gets the hips to shift a little bit. And again, it's really only when you're upstanding and moving around that shift takes place. And then when you sit, lie down, it kind of stays where it is. And therefore you only get pain when you're up and moving, because that's when the shifting is occurring. Hence why it doesn't show up a lot on x-rays, MRIs, things like that.
A question.
Sure.
It's pronounced sacroiliac.
Sacroiliac, yes.
Or is another L in there? Sacroiliac.
Iliac.
I always say sacroiliac.
Minus the one L.
Sacroiliac.
Sacroiliac.
Latin.
Sacro.
That's a Latin word, sacroiliac.
Sacroiliac.
Which is why we usually refer to it just SI joint. When you're in tomorrow, I'll test your spelling.
No, that's just the way I've always pronounced it. I don't think I've ever, or don't remember ever actually seeing it spelled out.
Mm-hmm.
And I know I've always heard it pronounced sacroiliac.
Mm-hmm. It's close. It's iliac, but again, because it's so.
Back in the vaudeville days, my aching sacroiliac.
Maybe that's what they came.
It was a joke, but it isn't a joke. It's
Yeah.
sacroiliac.
So
It's a Latin word. Most the anatomy of the human body.
most anatomy has that type of origin, but
Yeah.
anyway, that's kind of what happens in an SI joint or a sacroiliac. 'Cause I know it's a common term that people have thrown out, but a lot of people don't know exactly what it is and the difference between that and some of the other causes that we just spoke about. Okay. So I threw one extra one in there. Okay, we're going to talk briefly about the piriformis syndrome. Okay, the piriformis syndrome. I guess first what I'll do is I'll explain the piriformis. It's a muscle. It kind of crosses our hip, our tailbone, and it kind of comes outward to our hip. It's a little strip muscle about that thick, as you can see right here. The trick with that is we have that other yellow tube that runs down. That's our sciatic nerve. Who's heard of our sciatic nerve? Okay. A lot of times the sciatic nerve issue can become pinched at the level of the spine, whether it's a stenosis that's pinching on it, or a disc, maybe a herniated disc that's leaking out onto the sciatic nerve, we spoke about. But another one that's kind of tricky and can kind of sometimes get misdiagnosed or missed altogether is the idea of a piriformis syndrome. Where that sciatic nerve runs, if you can see, it runs right underneath that piriformis. What happens in a piriformis syndrome happens a lot nowadays. A lot of people have been sitting a lot more, maybe doing a lot of desk work, things like that. That piriformis muscle can become tight. It's very common to become tight and or just get some trigger points to develop in there. When that muscle gets tight, it wraps around, it wraps over top of that sciatic nerve tighter than where it's supposed to be. When you put pressure on that sciatic nerve, you get sciatic type symptoms. It could go down into the leg. Why I like to throw this one in here, a lot of times people will get the symptoms, they'll get maybe misdiagnosed as maybe something going on higher up in the spine. They receive the treatment, whatever treatment for that spot of the spine, they don't get better, they don't get 100% relief because maybe they are missing something actually down in the muscle. It could be at the muscle level that's putting a little pressure on that nerve. Okay? Good. So we're going to switch courses for just a moment. We're going to talk about imaging. When I talk about imaging, I mean mostly like x-rays, MRIs, things like that. Okay? I'm going to bring this slide up. I know it looks like a lot, but what I want to illustrate for you, the medical world has done studies, and we're continuing to do studies on imaging and if it truly is the cause of our pain. So to further illustrate, I want to bring your direction to this study right here. It's further back. You can see that they studied over 3,000 people without symptoms. And so what I mean by that, no back pain, never a history of back pain, no back injuries, anything like that. Regularly healthy in terms of the back. Over 3,000 of them they studied, they did imaging of. They found that at age 50, by age 50 or older, 80% of us are walking around with some form of disc degeneration. Remember, we spoke about that a little bit ago. And 36% are walking around with full disc protrusion. And these are people without any pain. So chances are, whether you had pain or not, or even before you had your injury, you may have been, if you fit into that category, you may have been already walking around with that type of abnormality on an image. Okay. The reason why I like to bring this up is because a lot of times we'll do these talks, or I'll have patients come in and they'll say, well, I was told on my image I have a stenosis or I have a herniated disc. They said that's the cause of my pain. Maybe that makes them feel like they don't have a lot of options for help. And we find that that's, in a lot of cases, 80% of the cases, that tends to not be the case. That tends to not be, they look at those image results as almost kind of like a death sentence, like I have this thing wrong with me that's causing my pain. We're trying to get the word out now, and you can see that they replicated these studies in a lot of different body parts as well. You can look at those high number of percentage statistics of structural abnormalities on images of people who did not have pain. So, if you're sitting there and you have back pain and you've been told that you have a herniated disc or an arthritis, something like that, and now you're confused because now I'm telling you chances are that that might not be the cause of your pain, then maybe you're thinking now, okay, then what is my pain? Now I'm going to bring that slide back. Mechanical back pain. If you can kind of pair up these studies, those high percentages, and now that 90% of us or more kind of makes sense. They kind of match up, right? 80% or more of us are walking around with structural issues with no back pain, but a lot of us do have back pain. 90% chance it's what we call mechanical in nature. Movement related, position related, okay? Like a car, follows a pattern. How about the stuff that we spoke about earlier? Herniated disc, but movement pattern. Even though it's maybe herniated, chances are that it's movement related. It's worse when I bend forward, it's better when I stand up. Arthritis or stenosis, it's worse when I'm upright standing, gets better when I bend forward. Movement pattern, okay? It still falls under, in most cases, that mechanical overarching term, meaning that we don't necessarily need that MRI because, as we just found out, 80% of us have something on there. And we find with a lot of people that just causes a lot of unnecessary anxiety, which then decreases your overall prognosis. If you believe that there's something structurally wrong with you that you can't get help with, mentally, we are already setting the bar kind of low for your chance of a successful recovery, okay? And again, movement related, pattern related, I'm gonna drive this home. If you can reproduce it, then we know how to reduce it, okay? All right, little trivia question. You've been paying attention tonight, you've been putting some clues together. Single biggest mistake that people with back pain make. Any takers out there? Anyone wanna take a stab at it?
I haven't it looked at.
It's a good point. Anyone else want to take a stab at it?
Not moving or not.
It's another good one. Since everyone else said the
What did he say? What did he say?
Not having, a professional examine your, like this, right here.
The strengthening, the PT doesn't always work. I don't know.
You guys are pretty good students. I've been doing these for a while. I usually don't get a lot of well thought answers. But, so the single biggest mistake, it's kind of similar with what you all said. Single biggest mistake is ignoring the pain, okay? So you listen to what I spoke about tonight. Maybe some of it sounds like you, but you still decide to ignore it. Or even if you weren't here tonight, just people in general. That's the biggest mistake that most people make with back pain. Earlier we spoke about the healthy mind versus the chronic mind, or if you've been having pain recently or if it's been going on for a long time. You get into that 3 months or more because you ignored it. Single biggest mistake. And I understand to a certain extent. It's a time commitment. Sometimes there's money involved. Sometimes you're dealing with several different medical professionals. Maybe they're having on different medications, things like that, and I understand to a certain extent. But ignoring it is still an issue. Solution then, of course, if the mistake is ignoring it, then the solution is to take action or to handle it, okay? Obviously, what we are here to preach is getting some hands-on therapy, to get a physical look at it, to get a movement specialist to look at that most likely it's mechanical in nature, to see if that is the case. Okay. Just an example of what a physical therapist can do. Again, we're obviously, we spoke about just a bit ago, we don't look much early on into the imaging. We want to look at your movement. So it's a physical exam. There's just a couple of pictures of what we do. Look at your flexibility, look at how you're moving of the back and the surrounding area to see what is off, so to speak. Your balance, your muscle imbalances, strength, flexibility, things like that. A lot of times it'll be the case that maybe you have a couple of muscles that are a little tighter than they should be from something you've been doing a lot in your life, a lot of sitting, things like that, and likewise, maybe a couple of opposite muscles have weakened over time. You have a little bit of a muscle imbalance. Then you're in a little bit of a weird posture and you do some movements, it's gonna hurt because you're putting pressure on parts of the spine in a way that it's not designed to, okay? That's what we talk about when we talk about muscle imbalances, things like that. Physical therapists are the ones who are the movement specialists of the human body, more so than any other medical professional. Real big believer in the medical system, and other medical doctors and things like that, they have their specialties. We are the ones who are trained, we're the ones trained in movement. So if you feel, based off of some things that we spoke about, you're thinking about some of these patterns and it is maybe related to movement, that's what you want to be thinking about. You want a movement specialist to be the one to look at it, okay? Now, a couple of hands raised earlier about therapy, physical therapy. You've done it before, well, maybe with success or not success. So maybe, what am I saying, or what do we do here that might be different? The one thing that I really want to drive home is that we use evidence-based practice, meaning we do treatments and interventions that are highly touted by research, the most effective treatments, cost-effective treatments to get you better as quick as possible. A big component of that is what we call hands-on therapy or manual therapy, which we spoke earlier about. Stephanie and I both have a couple of different certifications and licenses with hands-on types of therapy, and that really makes a significant difference in the outcomes. Don't get me wrong, we also are a big believer in exercise as well. But when we do exercise, it's very structured, it's very specific, tailored to your problem. So we don't do a lot of what the old school method is, like protocols, put you on the back pain protocol, a series of cookie cutter exercises. That's not what we do here. If you're going to do an exercise program with us, we have a very specific, based off of your examination. I do the examination with you, and I draw up your program specifically based off of that. So we have several people in the audience tonight. You all might be here in the room, in the clinic for treatment. You all, with back pain, you all might be doing totally different programs though if you're with us, just based off of your individual needs. And that's something that we offer here that may be different than other experiences you've had in the past. And so that's kind of what we might be able to offer a different experience for you. Now, I do want to mention, as I say that, I don't want anyone to leave empty-handed tonight. So in your folder, you do have one-page handout of exercises. These are very general, very basic, beginner-level exercises to kind of build a foundation. These are healthy, generally healthy and safe exercises for anyone with back pain, no matter what category that we spoke about tonight. Just to I wanted to kind of get everyone started on a little something, to get a little bit of familiarity with some movement, and then of course the real answer on what the best exercise is, based off of what I just spoke about, your individual needs and the specifics that we find out in your examination.
Dr. Jones,
Yes.
what role is it, fascia or fascia? What part does that play in lower back pain?
You say that again?
What part is it called fascia or fascia?
Yeah, it's usually pronounced fascia, but that is it's a soft tissue. It's pretty much the tissue that blends different connections of muscle and other soft tissue together. So it's a non-contractile tissue, so it's not muscle, but it is it's kind of at that layer. You can't develop knots, trigger points in that, so it can be a source of pain. That with certain type of exercise and stretching, we can kind of help loosen that up, similar to another type of soft tissue type of disorder.
Okay, but it's not a muscle.
It's not a muscle.
It's like a netting.
It's like a netting.
I saw it on YouTube, so I have to ask you.
Was it Bob and Brad?
I stay on YouTube first.
It's like a netting, or another way I describe it sometimes, it's like a saran wrap that holds all the muscles where they should be.
So then it gets stiff.
It can get stiff, it can get tight, it can develop trigger points and scar tissue just like the muscle layer can. So it can be a source of pain similar to that of a muscle is just kind of like the saran wrap layer that surrounds it. It's really, it's like a close cousin of the muscles, but it's kind of not.
You don't hear about that too often.
You don't hear about it as often, but it is a common source of pain that we find with people. So to kind of reiterate, hopefully we have
The pain is from the muscle or from fascia, can you tell?
in an
Or it
examine.
doesn't matter?
No, we can tell that, and that's a good question because that kind of leads me into my next slide. So how do you know for sure? Not just if it's a fascia or a muscle, or maybe you're sitting there thinking tonight some of the other kinds of back pain that we talked about. Herniated disc, stenosis, piriformis syndrome. How about even that overarching mechanical back pain? Now maybe you're curious if you fall into that 90%. Fascia, muscle, whatever.
Can you press some one?
Sure. How do you know? Well, here's what I want you guys to kind of think to yourself right now. Did anything that we talked about maybe sound like you tonight? Herniated disc, stenosis, things like that. Or maybe you thought something you had coming into tonight, and maybe something else I spoke about tonight you think sounds like you instead. Categories of back pain, how about the patterns of movement? Maybe it's not one of the type of diagnoses that we spoke about. Maybe it's, well, I do notice that it hurts when I sit for a long time, or it hurts when I'm walking for a long time and sitting down makes it feel better. Maybe any of those ring a bell to your particular problem that you're having. And how about what we just finished talking about? Do you want to be someone who makes that mistake and continues to ignore the problem, or are you looking for a hands-on approach? Okay? Think for a moment these bullet points, if anything sounds like you tonight, okay? If so, or if anything even remotely sounds like you, or you're curious of which category you may fall in, to answer Renee's question, that next step to take is from tonight is to schedule an evaluation. Okay? It's an individualized session. We look at your movement, okay? We look at, you come in and you tell us what's bothering you, what movements. We go through some specific movement testing, muscle testing, flexibility testing. We can tell. After we go through that movement screen or that movement test, we can tell, we kind of sit down after, and we are able to diagnose you, or we're able to categorize you in one of these spots. Is it a disc? Is it stenosis? Maybe it's a muscle, maybe it's a fascia, maybe it's a nerve. Some cases it's maybe a combination of, if it's been going on for long enough. So it's full body, specific to your problem. The best news that people like to hear, we figure out what your problem is, but we do treatment on the same day if you are interested. So we don't just poke you and prod you and tell you what's wrong with you and then send you out the door. I mean, we work to make you feel better on that day before you leave, okay? And that's kind of, like I said, if any of this sounds like you, what we kind of educated on tonight, that's my next step for us to take. Figure out what's wrong with us, specifically what kind of category we're in. Therefore, we can set you up on the correct treatment path for you, whatever that path is, okay? So before I open it up to the group, I have a couple of common questions that I tend to get. So I'm going to go through those first, and then before we break up, then I'll open it up a little bit individually to the floor after, okay? So you might be thinking, if you're even somewhat interested in evaluation, does insurance cover it? Yes, we go through insurance. Also good news for an evaluation with me, you don't even need a referral or a prescription. I have what's called direct access. Not all physical therapists have, but some of us do. It's just an extra license, one that I didn't even put, letters that I didn't even put on the introduction slide. It's an extra one, I have to add that, I guess. But it's an extra license that you don't need a prescription to come in for me to do an examination. And that's for this specific back pain that we want to tackle, and just for future references for anything else that may come up in life too. Oh, my shoulder's bothering me, maybe you know someone that sprained their ankle. Someone with direct access like myself, you can call us up, we can get you in right away. You don't have to go see someone else first, doctor or someone, to then send you here. Kind of cuts the middleman out, okay? Another one that I get, people with back pain, you're curious about, is it okay to be active? We find a lot of people with back pain, severe back pain, they have a little bit of fear of movement, fear avoidance we call it. What we're finding in research is that we're actually recommending that you do try to move, you do try to be active. Even if you do have back pain, we're finding through research that it is better prognosis-wise for you if you still try to remain active to some degree, even if it increases your discomfort by a little bit. Obviously, if it's going to cause you severe, sharp, agonizing pain, we don't want that. But if it causes just a little bit of discomfort, it's actually better for you to keep moving, okay? Best exercises are machines. We get that one a lot, which is why we try to solve that all ahead of time. Like I said, giving you the beginner exercises in your handouts tonight to maybe sample before you come in for an evaluation. And then obviously the best answer, the optimal answer, is kind of a trick question. The best exercises for you are the ones that are based off of your individual needs that we would only be able to find out in a screen or an evaluation type of scenario. Okay. Hopefully I've debunked, I've answered the next question already. I've tried PT before. Why would we maybe be different? And again, I hope that everyone can understand what we try to offer, some different treatment approaches that we can kind of help give you a different experience. And just all we're looking to do is to get to know your body, get to know your back, and get you on a treatment program for yourself, whatever that may be, different roads we can all go down. Okay. And the last one, sometimes we'll get people that aren't from around here, and I think when I surveyed the room earlier, a lot of you are from local to here. In the event that some of you are not from the Moon or close to Moon related area, well, I'll bring a map up in a moment, and you do have a list in your packet. We do have many other locations in the area. If you are from somewhere else and you found our workshop, or maybe you work in another area that we have a clinic close by that you can swing by if it's a little bit more convenient. If not, what I'm going to recommend is to stop in and see us, okay? So I'll open up in a moment to some individual talk and some questions. But like I said, my last thing to wrap up is that if I hope you all, and I saw everyone stayed awake, I hope you all enjoyed and learned something tonight. And like I said, I can tell that some of the topics that I spoke about really connected with you on a certain degree, because I could kind of pick up on that. So if anything that we did talk about sounded like you tonight, what we're going to do now as we kind of wrap up, Stephanie and I are going to make ourselves both available at our computers. If you if you seem like that case of getting to get an examination, what we'll do is we'll set up a meeting before you leave tonight, okay? Thank you.